So we're going to go to the second portion of our program today. So I'd like to welcome Dr. Victor Leung, who practices infectious diseases and medical microbiology. He's the medical director of infection prevention and control and the physician lead for antimicrobial stewardship at Providence Healthcare. He's a clinical professor in the Department of Pathology and Laboratory Medicine. So today, Dr. Leung will be discussing with us from data to decision, making the business case for innovation in patient management. So I really like Dr. Barrett's comment on better evidence, better data to make business cases. So this is really, I guess, a good segue to this presentation. So with this, I'd like to introduce you to Dr. Leung, who's joining us virtually today.
Thank you, everyone, and good afternoon. I'm joining from Vancouver, and I'm going to be hopefully giving some examples of what we've done with stewardship program, highlighting the impact of the data that we use and how that drives some of the developments of tools that we've collaborated on with clinicians and the antimicrobial stewardship program. So a lot of this time, hopefully, will be reserved for discussion towards the last part, and so I might skip over some of the content depending on time allotted to ensure that we have discussion time. So these are my disclosures. For this session, an honorarium was received from bioMérieux, but they have not provided review or restrictions on what I speak about today. So hopefully in this session, as part of the discussion as well, we'll be able to share our visions and key needs that motivate how we think about introduction of a diagnostic test and how it impacts patient management, discuss a bit about the business case development, and I'll come back to the business case throughout each of these examples. And then when we talk about diagnostic testing, really where that test implementation process fits into the pathways, and finally highlight some of the key lessons that I've learned in some of this work. So before I go into the topic of innovation in patient management, one of these things that we started early on thinking about when developing the antimicrobial stewardship program is, well, where are we going to be in 10 years, 20 years? Are we going to be in a place that has data integration, has excellent surveillance, behavioral modification, understanding how people think and act to be able to adjust that? And I don't want to. The reality is that we're not at a state that I'm going to show you now as an example of what's happening in terms of surveillance in some as an example. But I think that innovation doesn't have to come to a level that is overreaching, and sometimes it's just modernizing the way we provide care or staying up to date with the way that we should be providing care. And so this is an example of something that may be a bit overreaching, but I think some of the concepts apply when we think about, well, what is it going to be like in 5 to 10 years in terms of surveillance?
Sheng Dan co-developed the system. It took less than a year to get the first version up and running. Now she can monitor every resident from this office.
我们排摸的这个就是整个小区里面的楼房的一些信息。
We've mapped the residential buildings in the district. Which ones are occupied? Where there are vacancies? Where elderly people are living alone? Where care or help is needed? It's all stored in our system and can be called up in real time.
那么这样的一些基本信息呢，也都在这个微平台上就可以实时的调取出来。
Even those who do not dispose of their trash properly are recorded. Residents who aren't following the rules are captured on camera from 3 different angles. The so-called brain acts swiftly. Whether it's an illegally parked car or unsolicited advertising, offences can be handled by patrol officers who are connected to the control centre via a mobile app.
居村的干部或者是我们居村里面的志愿者发现问题
As soon as the squads and volunteers in residential districts spot an issue, they can report it and upload footage. They take a photo, report the issue, and then our system automatically decides which department to forward the matter to.
一个区分这个事项可能是由哪个部门进行有效的一个处理的。
The brain in Shanghai's Pudong district is just one component to the overarching surveillance plan the Chinese government is pushing across the country. The goal is to have...
Okay, so we're not at that state, and I don't think we'll be, but it'll be interesting to see if places in China have adopted that system for healthcare and how data integration, behavioral monitoring, facial recognition might play a role in improving or making the world a scarier place. So our antimicrobial stewardship program started in 2013, and our logo was based on this concept of having dialogue around bugs and drugs. And you might see that antibiotic schematic there, along with the pathogen and dialogue scripts. It was about having conversations, and something that was mentioned earlier in the panel was connectivity. I think with transformation from written charts, which we had when this program started, to trialing, you could see dated using a BlackBerry to communicate C. difficile real-time alerts. That has really changed since COVID with introduction of our electronic health records and use of different communication tools now has changed the way we connect and adapted to changes in interventions in antimicrobial stewardship. Now, our vision, though, has not changed. It's still considered a coordinated effort to optimize antimicrobials to minimize adverse events, excess costs, and the development of resistance. But as we heard before, some of these goals may not be compatible with how funding cycles are established and what funding priorities are. So we were fortunate back in 2013 when the program was officially funded. It was based on a business case, and credits to Dr. Andrew Morris, who at the time had on his website shared business case tools that have now been become available on the AMI Canada platform. Lots of the tools that are there that allow individual groups to use some of the framework, or just to take the tool right off the shelf and input the variables, such as the costs required for resources that the program might need, initial investment costs, operating cost data, and most of the development tools around this business case have focused on concrete savings from antimicrobial costs. So those are costs that can be easily obtained from the pharmacy, and has had a huge impact on, I think, many of the programs in Canada being funded. And for us, we initially, when we looked at the return on investment that was proposed, even using some of the conservative discount rates, it was very clear to our chief financial officer that the return on investment analysis was sound. And every year during the first 3 years of our program, we exceeded the expectations of the return on investment based on antimicrobial procurement costs alone. Now, this type of business case, when transported 10 years forward to the current time, may require some additional features to show a demonstration in cost reduction. And I'll go through some examples of that when I talk about our program. So we heard a lot earlier on the panel about urine culture volumes. So I'm going to talk about one project that we did at the beginning when antimicrobial stewardship was funded. Now, the program was funded in 2013, and at the time, most of the activity was based on what was traditionally practiced at the time with stewardship programs, audit and feedback, and some degree of restrictions. Our program didn't focus on restrictions and focused mostly on audit and feedback for antimicrobials. But we recognized early on that diagnostic tests drive antimicrobial prescriptions. And so looking at our 5 long-term care facilities exceeding over 1,500 beds, we looked at the urine culture volumes from our long-term care facilities. So from 2008 to 2013, you can see that the volumes are consistently quite high, above 600, peaking at about 1,000. What we did in 2013 was not a trial, but a quality improvement project based on what was already established data in randomized cluster control trials from Mark Loeb's group, which was to use a checklist and communication tool between or among the nurses and long-term care assistants and the physicians that are on call for long-term care. And the tool was audited with feedback with help of infection control practitioners. So we leveraged both the infection prevention and control teams as well as antimicrobial stewardship to help with audit and feedback for urine cultures. And it didn't require intense frequency or ongoing sustainment with audit and feedback. After the initial few months, it transferred to a frequency of every 6 months, then to point prevalence of every year. And now, since from 2013 to 2023, you can see that the volumes have been sustained to below 400. So that's more than a 50% reduction from our baseline that's been sustained without regular audit and feedback. And this was clearly dependent initially on the culture shift of communicating the checklist tools that were established. And we also showed that during this time, antimicrobials, specifically antimicrobials used to treat urinary tract infections or empiric use of them, had decreased significantly as well. So what I would say is I know that care home management is different in different facilities and across the provinces. But one thing that has been proven to work and should no longer be considered an innovation and should be a standard of care now is using checklists to determine whether cultures should even be obtained. And so with our program, what we were able to show is the fewer interventions of having to use in and out catheterization, fewer collections of urine cultures up front, so not even having urine cultures arrive at the lab. And that 50% reduction has saved not only laboratory costs, but now adding on things that can be considered return on investment would be planetary health impact and carbon footprint. Although as a test volume, it's still considered low in terms of its impact on carbon footprint. The fact that it's been sustained for more than 50% reduction over the last 10 years, I think is evident on its own that this practice has long-term sustainability in terms of financial impacts. This was at a time before AMI Canada had released their campaign in 2016 of the symptom-free P, let it be, and also before Choosing Wisely has endorsed this practice over the years from multiple groups. So I would say that for urine cultures, we should no longer, particularly in long-term care, we should no longer be thinking that this is new innovation and that long-term care facilities should not be doing this. This is now should be considered a standard of care practice. And one way to implement this is to think about how accreditation practices and standards in long-term care could affect policy changes in that type of facility. So Early on, we recognized that diagnostic stewardship does have a significant role in guiding treatment, and the World Health Organization in 2016 defined diagnostic stewardship as coordinated guidance and interventions to improve appropriate use of microbiologic diagnostics to guide therapeutic decisions. So similar to the vision of antimicrobial stewardship, it's promoting appropriate and timely care and timely reporting of results. Now, these aspects of core elements of stewardship have been summarized in long-term care, and definitely long-term care facilities can choose different things for reporting. But one of the things that's common among core elements is leadership commitment, and this ties into the business case, because if you have clear leadership commitment that's upfront, made aware to the organization, then it also helps with getting leverage when asking for additional supports from services such as data analytics team. And so when we transitioned to our new CEO during the program, 5 years into the program, one of the first things that we wanted to do was get our new CEO's feedback about what her thoughts are on antimicrobial stewardship, because antimicrobial stewardship success is entirely dependent on leadership support and multidisciplinary participation. So fortunately, our CEO was aware of the importance of antimicrobial stewardship and provided this quote when she started in her role at our organization. Now, thinking about other examples, the first example was about decreasing diagnostic test utilization, or making diagnostic test utilization more appropriate through a reduction in volumes. When we think about how that fits into the diagnostic test cycle, we know that from the post-analytic, pre-analytic forms, the hardest to control areas are the pre-analytic and post-analytic areas, at least in the lab, where you can have much more control in terms of standard operating procedures. The analytic component has much less unpredictability compared to the other two phases. So it's really important that when we think about introducing a test, that a lot of work is done on the pre-analytic and post-analytic side. So an example of this is another example that I heard mentioned in the panel is biomarker-guided therapy. So when we looked at our ICU and duration of therapies, we round with the ICU team bullet rounds twice a week. And through our review of duration of therapy as well as our experience, we understand that in critical care, it is often difficult without additional information to determine when it's safe to discontinue antibiotics that have been initiated. So this was one of the first strong randomized controlled trials that demonstrated the safety and efficacy of PCT. And I want to make it clear, because a lot of times the procalcitonin guided therapy literature is interpreted in a heterogeneous form for different conditions, whether it's for initiating therapy or using it for community-acquired pneumonia and emerge. Specifically, we wanted to look at PCT therapy in intensive care units. And so based on this study that looked at primary safety endpoints of procalcitonin-guided strategy in terms of superiority, and secondary endpoints in terms of reinfection rates, length of stay in ICU, and cost effectiveness, it was clear from the studies that this was a safe and efficacious intervention. So what we did with our ICU group when introducing this test with biochemistry, before even thinking about whether we would offer it, is a lot of discussion with the ICU physician team to familiarize them with the purpose of the test, and also some boundaries that we would draw for the pilot. And specifically, the boundaries focused on ordering algorithms and action. because if the test was ordered appropriately through the algorithm, then it should lead to an action by the ICU physician based on the algorithm. It was clear to them, made up front, clear that an agreement was established that if aspects of ordering, adherence, or action were less than 50% in terms of adherence, then this test would no longer be offered. And with biochemistry, we were able to start off this pilot initially through once daily PCT collection when ordered by the ICU team. And after initial review of the protocol and a 6-month pilot during COVID, it was clear that it didn't work. However, when we presented the data back to the ICU physicians on why it didn't work in terms of adherence to ordering and action, they provided the feedback that the system didn't allow them to familiarize themselves with the actions at the time, and so they wanted a secondary trial and to continue with the pilot. And so with revision of the algorithm and clarification of the algorithm, we finalized on this toolkit to do a second evaluation. And currently we are continuing with the PCT evaluation because based on our audit and feedback reviews, we find that it does have a role. And overall, when we look at the days of therapy, it is having impact. And so this has also been helped by increasing number of trials that show the role of PCT and that the care guided by PCT reduces antibiotic duration safely when compared to standard of care, provided that the algorithm is used appropriately and that there's appropriate diagnostic stewardship principles that are introduced. So I think we are one of the only ICU in the province that are using this. And when we look at other organizations that have PCT available, the reason it's failed is because they didn't involve their clinicians when introducing the test. And so the diagnostic stewardship principles of who can order it, how it's interpreted, have kind of sustained over the years by allowing anyone to order the PCT without action. And so one of the things that we were able to do is limit the ordering to a unit and to a setting where it will have significant impact as demonstrated by duration of therapy. And so integrating that data as one of the examples, we have a dashboard now with our data analytics team that looks at the 4 categories of utilization, antimicrobial costs, process metrics, and additional metrics that are designed specifically for programs that we introduce. So some examples of additional metrics would be for prostate biopsies and prophylaxis, where we can track readmission rates after prostate biopsies to reassure the urologists that our new antibiotic prophylaxis regimens don't lead to increased readmissions. And when there are readmissions, we can track to see if they're related to urinary tract infections or infections related to the prostate biopsy procedures, as one example. When we use this dashboard to demonstrate the impact of the PCT program, we can look at utilization. And on the left panel is trends in antimicrobial therapy, days of therapy in the ICU, specifically in 2019 to 2020, prior to implementation of the program. And we can see under days of IV therapy that, for example, Piptazo, when we compare that to current days of therapy for Piptazo, it's gone down from 24 to 19. And so some of these antimicrobial days of therapy associated with PCT or can be associated with the temporal introduction of PCT use along with our other stewardship interventions. Now, the previous example was about engaging physicians in choosing a diagnostic test that's going to work for them, but setting boundaries associated with diagnostic stewardship. Now, this example I'm going to speak about is refers more to replacing an older test with a more modernized test. And this has occurred now in throughout British Columbia for infectious diarrhea. The goal when introducing molecular panels or syndromic panels is to ensure that we have more timely results, having targeted treatments, and hopefully the targeted treatments will be associated with fewer inappropriate antibiotic prescriptions. So going back to the diagnostic testing cycle and the pre-analytic, analytic, and post-analytic phases, we have to think about, again, the pre-analytic and post-analytic parts as the largest areas of unpredictability. And when introducing this test, we also have to think about the conceptual approaches to therapy. And there are conceptual approaches dating back to 1989 that have been published from Kim and Gallus, looking at dividing antimicrobial therapy into areas of observation, prophylactic, empiric use, therapeutic trials, and specific therapy. And if we look into empiric use a bit more, a lot of the diagnostic tests now are trying to shift how we can get from empiric treatment to phenotype-guided treatment. So that starts from a syndrome, in some cases, gram stain, pathogen detection, genotypic detection, and finally phenotypic detection. I think the areas of debate and utility, debate around utility around genotypic versus phenotypic tests are going to be very specific to the type of disease or infection we're trying to treat. Thinking about this from intentions of prescription, from the clinician perspective, testing may have a role in prophylactic antibiotics, pathogen-targeted therapy, susceptibility-guided therapy, and also host customized therapy in addition to our empiric therapy frameworks. So putting that together, how did we think about introducing this test in British Columbia? First of all, there was a committee from all the hospitals involved, as well with clinicians, that put a lot of work into core recommendations for how this would be applied throughout the province, looking at testing indications, having some key messages on outputs or that must be treated or that lead to specific actions, and finally how we manage pathogens that are on the panel that also have targeted testing available. So this is a simplified, sort of adapted from the provincial guidelines of the approach. And this allowed for a framework and evaluation as well. So individuals who have acute diarrhea, more than 3 liquid stools, would be separated into 3 categories. And having these explicit categories with criteria allow for monitoring of how this test is being used and evaluation of its impact, not only on cost of the testing, but on appropriateness of ordering. It certainly helped us in the setting of an outbreak that we had in the Vancouver downtown east side in 2021, where diagnostic testing played a huge role given the number of patients that we were seeing in hospital and in the community, where we needed to sort out who could benefit from treatment to both shorten duration of symptoms and possibility of shortening transmission risk windows. And so the diagnostic testing that was being verified at the time in the laboratory helped with implementation practices during the outbreak setting. But one of the lessons learned now that we've had about 2 years with the infectious diarrhea panel is that there is, similar to before, over-ordering of stools for testing for infectious diarrhea. There's also some lessons learned from how we should be reporting out selective targets. And then finally, the need for more directed comments in the post-analytic phase to guide action. Since reporting a pathogen using a standardized format may not help the clinician necessarily guide treatment. So linking those comments to therapeutic tools that we have, such as our the first line antibiotic stewardship app has helped. But one of the areas that we're still working on is thinking about how do we reduce the over-ordering of the infectious diarrhea panel? Because when one of the fellows has conducted a review of testing that's been done through several point prevalence retrospective reviews, it's found that still a significant number, 30 to 40%, are ordered inappropriately. And if we have this data there that we can build into the dashboard, the ultimate goal would be to show how testing can be built into the dashboard, and as we can improve from sort of inappropriate ordering to more appropriate ordering trends, this can be fed back to the clinical teams during our education rounds, as well as a real-time basis for for healthcare workers who can access the dashboard that we have. Now, many places also have modified pathways for rapid identification of pathogens in suspected bacteremia and candidemia. And certainly over the years, we have implemented many of these different tools in bacteremia and candidemia rapid diagnostics. And thinking about how this has had an impact, a recent published rapid diagnostic tests for stewardship programs and the management of bloodstream infections in clinical infectious diseases used a systematic review and network meta-analysis framework to look at what the impacts are of traditional blood cultures on its own, along with antimicrobial stewardship interventions, compared to blood culture standard kind of procedures in blood culture identification alone, compared to rapid diagnostic tests in bloodstream infections, along with antimicrobial stewardship programs, and then finally using rapid diagnostic tests alone. And what the network meta-analysis looked at in terms of the outcomes included time to optimal treatment, length of stay, and mortality. And in short, what they found for the three outcomes is that for mortality, there is no benefit in survival when you just use the rapid diagnostic tests alone. And I think for people who have experience with the rapid diagnostic tests in system, if it's used alone, it's very clear, and this supports what they anticipate or expect, is that if you have a diagnostic test alone without antimicrobial stewardship programs, it's not going to help. However, there is significant reduction in mortality when you associate the use of rapid diagnostic tests plus antimicrobial stewardship programs versus blood culture alone, and with the use of rapid diagnostic tests plus antimicrobial stewardship programs compared to stewardship programs that only have traditional blood culture diagnostic testing. For length of stay, the reduction was associated with rapid diagnostic tests and antimicrobial stewardship programs alone showed no difference. And for time to optimal therapy, there was a reduced time in optimal therapy. And this was incremental reduction in time to optimal therapy when you compare rapid diagnostic tests with stewardship programs compared to blood culture testing alone or blood culture with ASB programs. So I think the evidence in the literature has also helped us adapt our program with bacteremias and candidemias. Our antimicrobial stewardship pharmacist rounds with the microbiology lab. And for blood cultures, there is rapid conveyance of the results from the laboratory to the clinician. And that is usually sooner than when the official result is reported. And because we have the communication channel of clinical pharmacists on the ward, as well as clinicians through use of Signal app or testing. And so that type of connectivity through communication with our clinicians and clinical pharmacists on the ward has helped us meet the outcomes that are expected, that should be expected from the use of rapid diagnostic tests and stewardship program interventions to affect these outcomes. So putting this all together and thinking about other examples, it's really important that when we try to convey and communicate these results, that we put together things in a framework that's going to be beneficial. And a lot of the time, it's going to be based on how well you can network and how well you know your finance team. And so a lot of the work that we've done has been with data analytics team and with our finance team when thinking about some of these key aspects of introducing a test or improving funding for an intervention for stewardship. First, it starts off with the value proposition. And the value proposition has to clearly state what the problem is, what solution you offer, and ultimately what the key impact is. Now, consideration for key impacts could be faster time to optimal therapy, reduce risk of complications, improved patient experience, and improved outcomes. But as we've heard earlier, unless you can make this real for the people funding this based on the priorities that they face, it's often going to be difficult in necessarily getting the funding immediately. So a lot of the work has to be done with your clinical teams so that you can leverage clinician feedback into advocating for introduction of the test. And the example that we had was with procalcitonin. So using the intensive care units support to help with introducing a test that they find valuable and that we can offer on a real-time basis or on-demand basis with actionable results. When it comes to antimicrobial stewardship, the business case obviously has to come back to the impacts on antimicrobial stewardship and how it combats AMR. So reduced days of therapy of broad-spectrum antibiotics are some of these standard metrics. Lower hospital-acquired C. difficile is usually easily obtainable, and in our institution, we've showed decrease of C. difficile, hospital-acquired C. difficile infections since the implementation of our stewardship program, and that's been sustained in the last 10 years. Finally, operational and financial benefits have to be clearly stated, and usually these are in conjunction with your data analytics and finance team in thinking about how they can gather the data to have impact in communicating the results. So reduction of length of stay, improving bed flow, enhanced lab efficiency, and projected return on investments. So the business case strategy has to demonstrate that the intervention or test is not an expense. It's not merely an expense, but really a strategic asset that's financially sustainable. And oftentimes, if you can show that this is financially self-sustainable over time, it makes, and at the same time, can make care delivery more efficient, effective, and safer, while addressing this central public health threat of antimicrobial resistance and tying it back to that central threat is very important and the key strategy in sort of overarching strategy in thinking about this. So summary of the lessons I've learned in the last 10 years is that I think that we can continue to do work in decreasing unnecessary testing because that can have a huge impact on not only lab efficiency, but reduction in antibiotic prescribing. And we're continuing to do work now through electronic health systems to try to automate some of these nudges to decrease unnecessary testing. We are facing a lot of barriers with the electronic health record because it's standardized. So a different approach that we're looking into that we've recently learned from our biochemistry colleagues is using the platform that doesn't allow us to decrease collection of testing, but allows us to, when we register the test through our lab information system and diagnostic interfaces, decrease the performance of the test. An example of that they've recently implemented in biochemistry is decreasing hemoglobin A1C testing just based on the temporal result of the previous testing and providing that result at the time of canceling the test. Another lesson is audit and feedback using diagnostic test results and how that helps with assessing antibiotic need. So we've done that with urine cultures. We do that with C. difficile tests, and obviously many places are doing that with blood cultures. Third lesson is that I think a very important lesson for us was really actively engaging the clinicians in determining and supporting the value of testing. Because for us, when introducing the procalcitonin, we would have automatically just canceled and stopped doing this test if it wasn't for the engagement of the ICU clinicians in seeing the value of this. Despite the initial failed pilot, it was from their request to continue with a second pilot that's now shown the value of this test. And finally, that lesson is that although rapid diagnostic tests help, it has to be combined with direct reporting to a team that can action on it. And in our setting, it's the antimicrobial stewardship team that helps with communicating the result and influencing changes in management in terms of antibiotic utilization, whether that be initiating an appropriate antibiotic or discontinuing antibiotics or changing. So what I'm hoping in the next time that we have is more of a discussion now in a group activity. Maybe in the next 3 minutes, if you can first think about a test that you implemented in the last year or would like to implement, and what were some of the challenges in the diagnostic testing cycle, with maybe a discussion on the focus of the pre-analytic and post-analytic aspects. And then finally, thinking about whether your tests warranted or will warrant a business case. And hopefully, with some of that time for you to think about this, we can then use the remaining part of the session to discuss your experience and your ideas.
I'm just getting, hi, Victor, we're here. We're just thinking.
Okay.
Would anyone like to step up to the mic? Hi, it's Larissa Matukis from University of Toronto. So as a medical microbiologist, we are always looking at introducing new diagnostic tests into our system in order to be able to promote, whether it is for stewardship purposes or improving patient care. There's always those outcomes that we're looking for to make improvements. I'd say, Victor, you guys in BC had introduced the enteric PCR, and I think that's a really great example of a provincial-wide initiative to really identify where there were improvements in patient care as well as financial savings as well. And I think one of the challenges when building our business cases is the funding models that exist in each of the provinces. And when we look at even introducing enteric PCR locally at our institution, we couldn't make a business case out of it in our own institution because it comes out of a hospital global budget. And it doesn't actually have an impact on inpatient care per se. It's more of a public health or population health initiative. And whilst we could diagnose individuals faster with their diarrhea, it didn't necessarily amount to, or the number of patients that are admitted with that diagnosis is so negligible that it's not going to have a big impact on the global budget or even on the microbiology budget. And most of the testing that we do in microbiology is very siloed budgets. And so it doesn't matter that you have downstream savings if it's an incremental cost to the lab. Oftentimes, it's very hard for administrators to break down those silos in order to be able to support increasing in investments in the microbiology lab for those downstream impacts, particularly if they're not going to be realized within their care setting directly, but more on a systems level. So hospital funding is very siloed from the system, and the microbiology budget is very siloed from even the hospital budget. So we eventually did find a way to bring in enteric PCR and find a business case for it. And I would say that the only time as a microbiologist in my 18-year career where I've been able to break down those silos was years ago in about 2012 when rapid diagnostics for respiratory viruses were just entering the scene. And we actually demonstrated that the downstream impact of having a 4-hour turnaround time with a rapid respiratory virus panel actually reduced the amount of time that patients stayed in isolation compared to our, thrice weekly batched homebrew LDT for respiratory viruses, particularly for influenza. And that was the first time that administrators actually recognized that this was a groundbreaking innovation that allowed a rapid test to be introduced that was going to be a mere $20,000 more investment in the lab for what probably amounted to hundreds of thousands of dollars downstream in patient savings, just respect to patient flow and isolation days. So I think there's, as you mentioned as well, there's a lot of, every time you bring in a test, it needs a different business case and it needs a different perspective on how it gets introduced. And it's not always evident to each of the administrators where the benefit actually is. I'll just leave it at that, and maybe you have some comments and something more to share if anybody else does as well.
Yeah, no, thank you for sharing that experience because, I totally recognize how those constraints of the political environment and the financial environment have huge impacts on how we approach this. I'm wondering for in Ontario, now that you've implemented it, are you required in part of the business case to demonstrate some of the initial proposals on return on investment in terms of year 1 to year 3, or is it implementation of the business case and subsequently there's no accounting for or sort of no accountability metrics that you have to show in terms of cost containment in say 2 years after introducing this?
Yeah, so great. So we actually haven't been able to do it on a provincial level yet. We're working towards that. But at our local institution, we are introducing it into the lab. We basically had to make sure that we could show that when we moved from culture-based methods to the PCR-based method, that it was at least cost neutral. So it was the only way that we could develop the business case ahead of time. It becomes very jumbled, to be honest. I think even having good accounting records, what the return on investment, well, there was no real investment because it's cost neutral to introduce. And so I don't think anybody is going to hold us accountable to introducing this specific test because we showed it to be cost neutral upfront. If we had probably demonstrated that we needed an investment upfront to show a return on that investment, then I agree. But right now, the unfortunate financial constraints is even if we have a return on investment of 1 or 2 years, there's still that innovation is in the implementation of that innovation is still being denied because it actually is taking more than a year or 2 or 3 to get a return on investment. So it's becoming increasingly challenging to introduce innovations in hospital global budgets that continue to shrink. And are continuing to, when they do shrink, I'm not sure if this is fair or not, but maybe disproportionately reduce the budget that is allocated to diagnostic services.
Yeah, and that's the challenge we've seen in stewardship programs, infection control programs, is that when you can show cost savings concretely, your budget may not increase. And part of that, when we had our business case approved for antimicrobial stewardship, was a discussion up front that when we would see cost savings, that budget allocated to our program would not decrease. And so that we would have to do internal changes to effectively manage the budget allocated. But the downside to that was at the same time, there was no increase in the funding that we got since 2013. What we've been able to do is just maintain the initial investment costs into the antimicrobial stewardship program. But I think that's one of the key challenges in the way cost centers currently function in many of the healthcare systems, is that there isn't necessarily promise of maintaining a budget that's been allocated to a specific group, even when success is demonstrated.
Yeah, I completely agree, Victor. And I think that's always one of the things that we advocate for is like we get punished for being innovative and bringing down costs, and that those savings aren't reinvested in finding additional ones. It just means that our budget gets lower.
Thank you, Dr. Victor Leung. We unfortunately have to end the discussion. It was a really inspiring and educational talk. Let's give you a round of applause.
Thank you.